He is interested in protecting the assets of the country, and he knows that if all women become healthy and start working, 27% increase in the GDP will be seen, 27%. So he's hoping that we will move as a healthy economy and we take it forward. So, and today we have the presidency of G20, and India has also emerged as the voice of the global south. Today in papers we have seen India is building bridges between global south and global north. So that is the position we are enjoying today. So quickly, if we can come out with policies that will bring women up to speed, then we, all of us under the leadership of the Honorable Governor, will be doing yeoman's service. So that is the why. Now how? We have been doing a lot of secondary research. We have been doing a lot of consultations, and now this is the final roundtable where we will get recommendations from you, and what we wish to do that could be your recommendations can become policies, your recommendations can give policy guidance. Who knows, tomorrow your recommendations can actually go through the process of legislation and can become an act. So this is what is our hope. I'm very happy to have all of you here, and Madam, thank you so much. And each one will speak for about 2 minutes and give their specific policy direction in their domains of expertise. So Madam, can we start with, Dr. Amresh, please.
Since you have already, Madam has already set the tone, it's not just the GDP of the 20 million deaths in India, almost 40% are women, and 40% of those are because of cardiovascular disease. And in that, 50% are premature deaths. Rate of control of hypertension is less than 10 to 15%. Rate of control of hyperlipidemia is almost non-existent, and rate of control of diabetes is also less than 10 to 15%. So we are looking at not only creation of awareness amongst the patients, but also amongst the physicians, as well as the general sensitization of the ecosystem. Needless to say that we need to go at right from the nutritional level, where we have better nutritional policies, to creating environment for physical activity for women, and especially when we have midday meal program and all, having better nutritional access as well as the right kind of nutrition access. Most of the policies are focused on reproductive health and anemia, and I think this kind of overnutrition, especially in South Indian states, Northeastern states, and some parts of North India, has become very important. And when it comes to the tertiary care and point of care as well, I think we need to have more friendly policies where we can manage these long-term diseases. And we still see that medical colleges are skewed, that there's 1 ward for women and 2 wards for men, 2 wards for men. That needs to be addressed as well. So those are my 2 minutes. I'll submit my detailed paper to her.
Yeah, that's perfect.
Thank you very much, Doctor.
Thank you very much, Dr. Amresh Rao. You have already given words from my mouth, what I wanted to say as a cardiologist and as a preventive cardiologist. What I have been saying in our school children, their curriculum, there is nothing about the health of the child as a primary prevention for hypertension, which is the most important factor to prevent, for prevention of early deaths, early cardiovascular deaths. So every child should know how much should be their numbers. So I believe that we don't teach them what should be their numbers for the blood pressure, which should be normal, which is abnormal. For a child of up to the teenage, it should be somewhere from 90/70 to 120/80 max. Beyond 120/80 as a teen, they should be taken as a pre-hypertension. And from 130/90, they should be taken as a stage 1 hypertension, which is not been simulated in their clinical, in their curriculum. And all the parents, they should be educated. Because once we educate the children, the parents get educated, the teachers get educated, the entire community is targeted in that way. This way we have to give the numbers for the cholesterol. Like nowadays we see the target of cardiovascular prevention and atherosclerosis minimization in the early process of sudden heart attacks and the sudden plaque rupture and sudden deaths for men, women, children, everybody should be targeted LDL cholesterol. The LDL cholesterol should be less than 70 for children as well as for the men and women for any age. If the entire lifespan longitudinally we can keep LDL less than 70, then everybody will be prevented from early atherosclerotic death. The third point is India has got high genetic burden. For that LPA, lipoprotein little a, it should be less than 70. If it is more than 70 for a 10 years old girl or boy, that means they are genetically predisposed to get early heart attacks. There we have to target their LDL cholesterol less than 50. This is from the Indian Lipidology Association. These are the target points. If we can maintain, then coming to diabetes, as Madam Karuna has told very clearly, that early diabetes is setting up in Indian children because of obesity, lack of exercise and all those. So we should check them. We are not checking them. We have to check their HbA1c, glycosylated hemoglobin percentage. Once or twice we just check their blood sugar and we think that they are not diabetic, but that is wrong. We should check the HbA1c from the age of 10 years onwards, those who have family history and those who don't have, before 20 at least once. That should be less than 5.6%. If it is more than 5.7, they are pre-diabetic. If it is more than 6.4, they are definitely diabetic. That should be targeted points. So these are the basic metabolic factors. Then waist-hip ratio, more than the weight, which is very common in the Indian women and the children. They are increasing like anything, the girth of waist. Even our non-obese children have got obesity in the abdomen, that is bad fat. So these are the key points we have to target for the primary and secondary prevention. Thank you, sir.
Honorable Governor, Madam, I'm Kamal Kiran, a nephrologist. I'll try to be concise and stick only to kidney diseases. In India, the prevalence of CKD is almost 16%. As compared to the Western countries, it's 10%. This is a big study that was performed recently, 21 it was released. This means that every year, at least 30,000 population, out of which 15,000 women enter dialysis every year. In India, the projected estimates for people who would require dialysis is almost 1 million people, but hardly 1 lakh get dialyzed because most people don't get access to healthcare or they just don't reach dialysis. Women especially develop CKD because of pregnancy-induced hypertension, infections, autoimmune diseases, and obesity, other than the traditional risk factors of hypertension and diabetes. CKD is the 8th highest cause of death among women. And most people who have CKD don't reach dialysis because they die of cardiovascular diseases. Hardly 10% reach dialysis at end-stage renal disease when they start off with CKD. So approximately 3% in their childbearing years are affected with kidney disease. So that's very important thing in ladies. And women who experience preeclampsia or pregnancy-induced hypertension are 4 to 5 times more likely to have kidney failure and 3 to 4 times more likely to have a heart disease. All these are published studies. So, and babies born to these mothers who have eclampsia can be born with IUGR or fetal growth retardation who have a lesser nephron mass and in future can have chronic kidney disease as well. So although globally the disease is as common in women as in men, less number of women receive treatment. In Andhra Pradesh, and it's not only economic, because Andhra Pradesh, the dialysis is free like everywhere else in our country, but in the dialysis population, 73% are males and the rest are females, because females don't come to hospital or not brought to hospital or just neglected. But on the other hand, women donate more kidneys than men. 90% of kidneys donated across the country are women, 10% are men, but are less likely to get kidneys because of all kinds of reasons, socio-cultural. The lady is very happy to say, I don't want to take my husband's thing, I don't want to sacrifice him, but is very happy to sacrifice her kidney to her husband. 25% of kidney disease is associated in women with obesity as compared to only 13% in men. So obesity is a major factor in women for CKD and cardiovascular diseases, much more than that in males. So very simple recommendations is most about prevention and screening. Assessment of kidney function, a very simple blood test called serum creatinine and a urine examination as a standard test for all women from preconception and antenatal care till the rest of their lives. increased awareness of kidney disease as a risk factor and more public awareness programs to be done. Follow programs for those patients who have been diagnosed with chronic kidney disease, because just giving a diagnosis and then lost for follow-up. Monitoring of such individuals born preterm or small for gestational age and continuous monitoring toward their life, especially in the female population, because females are disadvantaged because they are born with a lesser kidney function compared to males to start with, 15% lesser than males as usual, because of lesser nephron mass and a smaller kidney. So implementing systematic screening for kidney disease risk factors such as diabetes, hypertension and obesity in women throughout their health course. There are simple things that can be done to decrease the rates of kidney disease in women. Thank you very much.
Yeah. This way. Okay. Thank you for this opportunity. I would like to focus on women and diabetes in the rural area. So we make lots of policies, and most of it's reaching the people in the urban areas. So I would be really happy that the government make policies to reach out to the 70% of our rural population, and only 30% of doctors who are there to take care of them. So if we can have a policy where more and more people, particularly the healthcare professional, should be given training to say screening diabetes, screening for NCDs, because we are moving more towards NCDs more than the infectious diseases. And we are experts in tackling the infections, as we have seen in COVID management. I think if we have to concentrate on better health of our nation, NCDs have to be tackled, and we have to have a policy to take care of the rural population through the rural healthcare professional. So this is what I would like to say, and more of that I have written and given you. Thank you, ma'am.
Good afternoon, everyone. Yeah, subject to correction, many a time the policies so far have been, if women's health means mostly concentration on nutritional aspect and gynops part. So as a physician, all the diseases like hypertension, diabetes, anemia, everything, they are routed through us only before going to specialties, except for 5 to 10% nowadays. So we are in more touch with the women and men everywhere. So my suggestion is that all the statistics that are made in the textbooks is Western based. We don't have any Indian context regarding the statistical health issues of women. But what we find in our day-to-day practice after 40 years is a lot of women suffer from all the diseases, maybe 5 to 10%, this variation is there. So, but whatever some of our colleagues' suggestion of all those cumbersome procedures is very difficult even for the government to implement also. But simple thing like screening camps, hypertension, you don't need any investment. Even simple blood sugar estimation, you don't need anything. Just simple urine examination to find out where any kidney problem is, they don't need much investment. So from our side, as a chairman of API Telangana State, we extend full cooperation to Her Excellency, whatever the recommendations to say that we can, because we have nearly 14 district branches are there, all our physicians are there, they are more acquainted with all these diseases before we send to the specialties. So screening camps both for hypertension, diabetes and kidney disease where we can, with least investment, because if we go on waiting for HbA1c levels, it's not possible even in urban areas. Forget about rural areas. So let us concentrate more on wherever if we find some focal areas where you find a lot of hypertension patients or some areas diabetes patients are there, then we can concentrate on that particular area and get some special camps to see that what could be the cause for that one. So in that way, I think government can plan with recommendations of Her Excellency. So we are there at any moment to help the community and the government from our side. We can depute, we have all other contacts are there. That's my suggestion.
So, one second, Dr. Sairam. We will go a little like this and then come back to you. So, you can keep the mic. Can we have Dr. Vimi Bindra share her?
I'm a gynecologist, but I am here to talk about a particular condition which affects women. It is called as endometriosis. 50 to 60% of women have crippling pain because of endometriosis, and 40 to 50% patients may have infertility as well. It affects 1 in 10 women, and approximately 42 million women in India are suffering. But it is a highly underdiagnosed, underfunded condition which is not getting the attention which a diabetes gets. It is as common as diabetes, but if we look at the statistics only in women, the prevalence is same as diabetes. But hardly people are aware of it. And it's not only the awareness for patients and community, it is also the awareness for doctors, because these patients are treated as if it is only a reproductive organ disease. They treat their ovarian cyst, but this disease, approximately 33% patients may have bowel involvement. There may be a 5 to 10% of urinary tract involvement. We might lose their kidneys because in 40% of the patient it is a silent disease. So patients sometimes they report as a hydroureter and all that, and there may be a residual kidney function of only 10%, and she might land up with nephrectomy if endometriosis is not looked into. So awareness and many myths surrounding endometriosis make this condition difficult to diagnose, and it is not addressed at the appropriate time. And it is a slowly progressive disease, not a cancer, but it is a locally invasive disease which invades the adjacent organs. In turn, patients have poor quality of life, absenteeism from work, productivity is less, they are not going to the higher jobs categories as Karuna ma'am. Yes, torrential pain, and they have been dismissed not only by family members, by doctors as well. You get married, have children, you will be fine. This is what my patients come and tell me. Patients are operated multiple times, 6, 7 times without any relief. There is also lack of experts for excision surgery. Gynecologists are not treating the disease completely. They are removing only the ovarian cyst and uterine disease, but what about the bowel disease? So these patients land up with the residual symptoms and they have multiple surgeries. So it adds to their financial burden, it adds to their societal, emotional well-being as well. These patients, 10 to 15% of these patients with pain have attempted 1 or 2 times suicide because they are dismissed and they are not paid attention. So as a EFI, like Endometriosis Foundation of India, we are trying to raise awareness, and if we can implement guidelines and quality of standards of endometriosis treatment, diagnosis and care, increase education at a caregiver level, investing in endometriosis awareness through a public campaign. Also, if we can develop a registry for endometriosis, because this is a locally invasive disease, facilitating an India-wide campaign where we can have patient advocacy program, where patients who have gone through the disease, they help educate others, establish partnership with relevant policy stakeholders to ensure a comprehensive and collaborative approach to address problems of endometriosis in India, and initiate discussion with insurance providers to get this disease covered, because first 2 years of taking the insurance, this disease is not covered and they say it's a chronic condition, they do not cover it. So people who are financially not very stable, it becomes very difficult for them to avail the quality of care. And also if we can have inclusion of a chapter in the textbooks where myths surrounding the periods can be included so that people have the right information and we can take it forward. Thank you.
Thank you for organizing this, ma'am. I'm an infectious disease physician, so I'll be focusing on various infection-related issues. The first and foremost I'd like to talk about is HIV. HIV has been with us for about 3 decades now, and women are particularly more vulnerable to HIV just because of the way the body is made. They're at the receptive end and there's a lot of mucosal surface, and so there's a higher risk of getting infected with HIV in women through heterosexual exposure. And 60% of the people who are having HIV, at least in sub-Saharan Africa, are women. Data from India, at least published data, is not available in significant numbers in terms of most infections, and including HIV and TB. Once they're infected, women have more challenges in seeking medical care, like for any other diseases. So they tend to have more severe disease, and they tend to also succumb earlier than men. Today, HIV is a chronic disease and can be tackled with any other diseases like diabetes and hypertension, but for that you need to be under treatment. They also are at risk for recurrent vaginal infections, pelvic inflammatory diseases, and the other challenge is communication of the diagnosis to women. If their partners are infected with HIV or hepatitis B or hepatitis C, syphilis, any of this, that information is not translated to the partners. And so the partners don't get screened and they don't get diagnosed, so they don't get treated. So that's another major component. So decreasing the stigma and improving access to health care for women in HIV. The other major topic I would like to bring about is tuberculosis. Tuberculosis, like the Prime Minister has told, we have to eradicate tuberculosis by 2035. But in particular, extrapulmonary TB and in women, genitourinary TB. We know that genitourinary TB causes infertility and probably accounts for about 10% of infertility. But why do they get it? More research needs to be done in terms of the pathophysiology as well as in terms of diagnostics. It's very difficult to diagnose extrapulmonary TB in general, and genitourinary TB is extremely difficult to diagnose. So improving diagnostic facilities for this disease definitely helps long way in improving the health of the women and in terms of maternal care. Both these diseases again can affect children as well. So there are a bunch of cervical cancer is another thing. So I will stop with that and.
Yeah, Dr. Vasuprada.
Ma'am, so I'd like to talk about two radically different things. One is about women's mental health, because mental health as such is still a hidden subject. Nobody wants to really talk about it. But in terms of women, where they really require help always is starting with PCOD. Girls who are going through PCOD have a lot of mental health changes and they do not get any support. And then the next level is to have during pregnancy. So pregnancy, postpartum, many cases are triggered at this point, and they do not have anything called a parallel counseling process, because what we have is a focus on nutrition. We have many other things excepting mental health. So women actually do not get that support. And the next level is, of course, the premenopausal, perimenopausal and menopausal stage. Again, there are many mental health issues that are seen at that time, and we do not have any mandate saying that at this age when they are seeking help, they need medical support, mental health support. So I sincerely recommend that when we are talking about any maternal health care, mental health support should become a mandatory thing. And the next thing that we have as a one big problem, which is not probably ever addressed, is addictions. Now we have a population of 10 crores who are considered to be addicts, and this is only what is statistically seen, and out of which women are written as the hidden numbers. Women are never known in these numbers, and we have almost 2 crore teenagers who are addicts, and we do not have any support in terms of de-addiction is just one part, but rehabilitation. So there are no de-addiction centers to manage the rehabilitation of all these addicts, and especially the young people and girls. So what we know is girls are not sent for any treatment because we do not have de-addiction centers dedicated to women anywhere. In fact, only recently we just started a very small place some somebody else started, so I helped out with that. But we do not have any de-addiction centers for women, and that's a security concern. You cannot really send them for all this. And young teenagers, so many girls, and it's not just alcohol, it's cannabis is very, very highly used now, and opioids. So this is my recommendation that we should really work on having proper de-addiction centers to be established, wherein a middle class average person can go, because we have always a disparity of either the availability for probably the lower socio-economic groups sometimes, but average middle class person cannot get any help. So this is what I just wanted to say. Thank you.
Good afternoon, Your Excellency. I'm a psychiatrist and I work with social cause. So we are a medical minority as it is. We are 0.5 to 0.75 per 1 lakh population in India. We have all of 24,000 counselors and 8,800 psychiatrists for the whole of India. So the need of the hour, is we are missing out on so much because we're just not there. So for the first question I need to ask is, where is mental health and why do we not figure in, why are we not figuring in the entire schema of medical health? We have seen most of the physicians also, with all due apologies to all the physicians here.
So they're not able to see. So we have, the Prime Minister has brought together many things in terms of transformative policies like assisted reproductive technology. And today you'd be interested to know that the country is working on a registry for rare diseases. Now, we have also seen the results. The sex ratio has improved. The maternal mortality rate has come down dramatically. And there are many things that are happening in the arena. But today we have congregated here for one important reason. In the year 2013, there was a global report. There was a global report on the global disease burden. And that particular report categorically said that India doesn't have women-related disease statistics. So our Prime Minister doesn't let anything pass. And from that time, we have started understanding women diseases specifically. Today, we know that the female death rate has almost doubled because of NCDs. And we have seen that women who are diabetic have almost 45% more risk of having a heart attack. 70% of chronic pain patients are women, but unfortunately, 80% of the research is done only on men. So women suffer more and they get treated less. The last and the most important thing today is our medical ecosystem, and the Honorable Prime Minister knows there is a fundamental difference between men and women. Physiologically, anatomically, genes, hormones, it could be fat composition, it could be lifestyle, environment.
Early stage, and then heal the healer. All of us need healing at some point. The pandemic particularly, we had free helplines for doctors also who just needed to unload and to help us shoulder the burden. A physician of any specialty, there is a 40% chance of a physician more than the general population to commit suicide, and for a woman physician, 130% more risk of committing suicide. So you see the magnitude of issues within the medical profession themselves. The third thing is insurance. There is no insurance for us. They're just trying to introduce insurance for mental health, but it does not address the mental health concern to women. Young teenage children, suicidal tendencies in children, the educational stress, this is something that we need to address. Can we make counselors compulsory in every educational institute, whether it's a primary school or even a play school? The other thing is, can we make community service compulsory for psychiatry residents and psychiatrists and all physicians who are concerned with mental health? So, because it does not reach the villages. The other thing is the fear of medication. I think this is something we need to address as an awareness program that says, just like you're taking a diabetic medicine, psychiatric medicine is also medication, it's also treatment. The last thing is if we can introduce, training the trainers in the sense like train medical professional and train paramedics to go into the populations to talk about mental health in the rural population so that it's more acceptable as, and I don't know if we can do something about the divorce laws because I think 70% of women with mental health issues face abandonment, divorce, abuse. So can we do something? Because don't think, the amount of women who are subjected to divorce because of mental health illness is almost 150 times more than men who face divorce proceedings because of mental health issues. So these are all, the things which I wanted to talk to you about, ma'am. I think this is more like a general thing. Thank you so much.
Thank you, Dr. Purnima. May we have Dr. Sairam speak, please?
Cancer is the second commonest cause of death, and among cancer deaths, women cancer deaths are more, madam. In India, we have almost 130,000 women with cancer, madam, and out of 5 lakhs all over the world, and almost 80% of them die, madam, in spite of so many advances. We have head and neck cancers, again common in men and women, because more of women are taking tobacco habits. So tobacco ban is not literally possible, and lot of funding is done by central government, madam. Almost all the cancer funding is by central government cancer control program, and it is coming to regional cancer center, madam. But the appointing authority is not the government, like in army, madam. President of India is the appointing authority. So I was in BSF, so we'll be more loyal to the President of India, the country, and the funds will not be diverted, madam. So when the funding is from Government of India, we should try to have more and more cancer facilities in our organizations like ESIC hospitals, railway hospitals, defense hospitals, and whatever centers we have, like we have National Tuberculosis Center, but we don't have a tuberculosis screening in the center. We depend again on the local things. Local governments are only providing the paraphernalia, but rest of the all funding, major funding is from our central government, madam, and we require screening programs in our institutes. CGHS hospitals are there, so many like BSF, CRPF, so many hospitals are there where we can do lot of our programs meticulously without any wastage of money, madam. I have given my representation, madam. Human papilloma virus vaccination is must, madam. We have, most of the countries in the world have human papilloma virus vaccination. Unfortunately, in spite of having highest number of cervical cancer deaths and numbers, we don't have. Now we have indigenous vaccine, madam, which is available only for 250 rupees, madam. And Government of India is planning to procure lot of this vaccine and start it, madam, but only your word and will hasten up the things, madam. Thank you, madam.
She is also a surgical oncologist. Then it will come back to Dr. Alva.
Especially women's cancers are on rise, especially so the breast cancer. 1 in 28 women is likely to get breast cancer, and other cancer, common cancer like cervical cancer is little on degree size trend, and oral cancers. Those are 3 common cancers. We should at least make these 3 cancers as a notifiable disease so that we know the burden of the disease, so that we can plan what is the burden. If you know only, we can plan for the screening, early diagnosis, and we should have a proper registry in the state. And even educated women are coming in the late stages. More than screening or this, but we need more advocacy in this cancers, in spreading awareness for cancers. And so as Dr. Sairam told, there is indigenous vaccine now, and government is going to provide free for everybody. We should make, we should educate people to take that vaccine. That's the main thing. Thank you.
Good afternoon, madam. I am an orthopedic surgeon. From the women's health point of view, in orthopedics, we are regularly seeing a lot of osteoporotic patients, and osteoarthritis patients. These are the two common problems we are seeing in the present society. So to prevent the osteoporosis, you have to start in the childhood, because the peak bone mass is reached by the age of 25 to 30 years. So before that time, we should see that they attain the good bone mass. So to get that from the childhood, they should have good physical exercises, and they should have good vitamin D intake. Vitamin D is not available in the food, it's only by sunlight. So getting exposed to sunlight between 10 to 2 p.m. That's off late. Earlier we used to hear that is in the early morning and early evening. Off late, research has shown that it is between 10 to 2 p.m. we should expose to sunlight. So with that we get good amount of sunlight. Added to that, we should have good physical exertion, and next we should have good protein diet. These three things will make good bone content. So by the age of 25-30, we attain the peak bone mass. After that, the bone, we will be losing the bone every year by 1 to 2%. So that's why to have a good woman health, we should concentrate it in the childhood up to the adolescent and young adult. So we should have screening programs of vitamin D deficiency, and we should have a good fortification of, like in Western world, they fortify bread, milk and everything with vitamin D, and we should encourage to have more calcium containing food like dairy products, green vegetables. That aspect we have to teach, we have to educate the masses. And in the government sector, to identify the osteoporosis early, we should have screening programs like BMD test we have BMD by ultrasound and BMD by DEXA. These machines should be available in all the government hospitals to have early screening. After having osteoporosis, treating is a little bit late. We have to screen early. We should identify, and we have got good drugs to treat also osteoporosis early. So we should have many centers in government, at least medical colleges or district hospitals, all the scanning with ultrasound machines or BMD by DEXA. And next is vitamin D is very prevalent. I'm a general practitioner orthopedics. I've seen many even educated people, in the city people, I see lot of vitamin D deficiency. So these vitamin D identification camps, we should conduct camps, and we should encourage them to get every 2 years one BMD test done. After 40 years, all the ladies, they should get BMD test after, because it's all something like an iceberg phenomena. There's only few people, only the fractures we see. With osteoporosis, we get lot of vertebral fractures, low backache, lot of loss of working hours for the society. To have a good society, we should have the good quality of the bone. So I keep telling my patients, Nadaka unnavadu adrushtavantudu, enda tagilinavadu bhagyavantudu. Means whoever walks and whoever gets exposed to sunlight, they will have good quality of bone. So we should educate masses, and at the same time, government should start centers having screening centers for vitamin D deficiency and decreased bone mass. And these two things. And of late, one more is osteoarthritis. Osteoarthritis is very prevalent, especially if it is associated with osteoporosis. It is even difficult. We are doing day in and day out a lot of replacements. But in the poor quality bone, to do a replacement is also a little bit tough job. So the results will be good if you got a good bone quality. So we should have, the majority of the poor people are also suffering with osteoarthritis. So it's a very costly procedure to do a arthroplasty. So government should make some more, already the present government is doing a lot of arthroplasties. They are encouraging all the government hospitals. They are doing even district hospitals. Very nice. It's a welcome feature. So the arthroplasty should be more affordable to all in the government hospitals, at least for the poor. That's what I want to say.
Thank you. Doctor, you have made notes for us. You have some notes for us. Okay. So may I now request Dr. Nandakishore to speak, please.
Good afternoon, ma'am. I'm Dr. Nandakishore, bariatric surgery. So I deal with nutrition, but on the other side, overnutrition. So today, if you think of the non-communicable diseases like a hurricane that is surrounding our country and troubling us, obesity tends to be the eye of the hurricane. So it is the the root cause of many of such conditions, and then we are able to control that. We can actually get a very good control on other NCDs. Now, having said that, the national survey shows that there's about 9% prevalence of obesity in our country. In a 1.4 billion population, having 9% obesity is a substantial number, and there are hardly, I would say, a few thousands of specialists who are dealing with this problem on a day-to-day basis. Now, this is not only limited to the adult population, is also in the adolescent population. We're seeing about 16% incidence of overweight/obesity in the adolescent and school-going children, especially in the urban areas. But with the work from home situation, the same obesity has now moved into the tier 2, tier 3 places also. So it is wildly prevalent everywhere. Now, how are we handling this? At least in the urban areas, there is a lot of specialists here who can help them. But moving into the tier 2, tier 3, there is a lack of education, lack of support. So we are hoping that, number one, to recognize obesity as a disease nationally. And so the additional services and support can be availed by all the population. Number two is empowering the suburban and rural healthcare practitioners and providers, qualified, unqualified, give them basic nutritional training so that they can guide the people. They can check along with the way they check their blood pressure and pulse rate, etc. They can check the height and weight and calculate body mass index. Very easy to calculate, and then guide them appropriately to take the right steps, the right nutrition. So this is one segment, ma'am. And the second thing, which is, I'm also into technology besides being a surgeon. I've been looking into this material called graphene oxide. So what is the relation to this in this forum is that there's a large amount of women who are struggling with poor menstrual care, menstrual health. Now, if you go into rural area, the sanitary pads are not available. At best, they get maybe one per day if they're lucky. And this is an unfortunate situation. Now, where does graphene oxide fit into this? Is that this particular material, if you use this to coat or leave a strip of graphene oxide in the sanitary pad, it reduces the bacterial growth substantially. It also has a very high absorptive capability, so even a single pad can help a suburban rural lady who can't afford much to take care of herself better. And also reduces the odor. So many benefits are there, and it costs hardly a dime on the dollar just to add this graphene strip into the sanitary pads, and it can be mass produced. In Telangana state, we are among the first to actually come up with this graphene oxide production lab. So I think this is one more area where we can contribute to women's health. Thank you.
Thank you. Thank you, Dr. Nandakishore. Now, may I request Dr. Chandrasekhar Puli to speak, please?
Thank you very much. I'm sorry I had to get up because the father would go away. I could not see. So my name is Dr. Chandrasekhar Puli, and I'm glad I'm here. I should be thankful to be back in this country. I left 22 years ago to UK. I've been working as a senior consultant there. So there's a lot to cover in gastroenterology, but I just want to break down this into 4 different points. One, to give the background and what differences I've seen between UK to India and how we can make it. Major changes come from simple topics. This is what I'm going to talk about, and the screening and how I'm going to collaborate into action plan. That's what I'm going to go. So the first thing I noticed in my practice, I've been in this country for 18 months to 24 months, and I looked at my data in the last 3 months. I have seen 4,848 patients, of which the men are more, around 76% are men, and the women are less. And out of this women's data, I've seen that people come with the lower GI symptoms, especially change in bowel habits or diarrhea. The presentation is very, very less. If you look at it, I've seen my own example that in UK, it's actually the same 50% men and women have the same problem, and we do the cancer screening in those patients in similar fashion. What makes the difference here? My mother has both upper GI and lower GI symptoms. I did the gastroscopy, and I have inhibition to do the colonoscopy. Why? And it's the same thing everybody faces through. And we have different cultural activities here. We have different communities. They don't like to expose themselves. Then how can we break the taboo? Number two, and the screening, and we can divide the gastroenterology into acute and chronic, but I'm not interested in the acute side, because when the government gets involved, we should look at smaller things to make it big changes. That's what I believe in, because I've been practicing quality standards and I've been in charge for the quality standards in UK. The only thing, my first point for this meeting is to bring the cancer screening. I've been in association with the Royal College, and they would like to enroll them in this country. What we first started as a bowel cancer screening program in UK, and they asked me, the Royal College Vice President asked me, can we roll it in India? How can we do that? There is a lot of difference to do that. Daycare centers can be established to get that action going on. And how can you get the women get engaged? If you look at it, in UK, like just everybody is mentioning, the lady gastroenterologist, even in UK, was 22%, and I expect it's much, much less in this country. Would a woman go to a male gastroenterologist, especially in the young age group? It's very difficult. How can we break this? Through education, and sometimes we provide them the dignity, which is what I practice in my clinic, and I have this special Bermudas type thing, which only exposes a very small area. Hold that. So, which gives them the dignity, and it only exposes a very small area at the back where we can do that, and we can educate the people so that they can come forward. Actually, to train the female gastroenterologists, we're talking about decades. We can make this thing simple. And also, we provide the dignity and privacy to the women, which is more important. We practice at London Gastrocare, my hospital. The women will be chaperoned by only female people in the room, except the endoscopists. I get a number of phone calls. Do you have a female gastroenterologist? When I educate them about what we practice in our place, there's a lot more people who come there. So, in a nutshell, I want to roll this as action plan. One, we should get the bowel cancer screening, and the Royal College is happy to come and associate with us to run the bowel cancer screening program. We educate the people. We provide the women dignity and privacy that will make positive changes. And I wish that we can take it to the next level. I can't cover all the gastroenterology in this session. I just want to make one thing, one time, one change. Thank you.
Thank you, Dr. Puli. Now may I have Dr. Gayatri share her views.
Namaskaram. You are a doctor yourself, so I'm sure much of what we talk today makes a lot of sense to you, and therefore we approach you with a lot of hope and a lot of expectations. I'm going to talk. Basically, my interest is in blood disorders. Although I do a lot of diagnostics, inherently in my practice I'm involved with a lot of physicians who take care of people with blood disorders. I know that many of us have this concept that anemia is being addressed always, and the government of India talks about anemia, has a lot of programs that are on its health policy programs. But I would like to talk about two forms of anemia today. One is the one that is related to nutritional deficiencies, and the other forms of anemia which are inherited blood disorders like thalassemia and sickle cell disorders. The thing is that either of these is preventable. Because these are preventable, I think our focus on these will really be gratifying and will make a lot of difference across the population. So we know that the current National Family Health Survey tells us that more than 50%, almost 60% of women in the reproductive age group are anemic. We also have similar figures for children. So we are actually talking about a majority of our population being anemic. So what we need to do would be to identify those who are nutritional deficiency related and those who are related to these inherited blood disorders. So first point is to be able to detect anemia. Second point is to be able to diagnose the basic cause and then move on further. For this, awareness I think is the first and fundamental step. We need to tell our people, especially our women, that being anemic is not something they need to live with. They need to fight anemia. So how do we tell them? We need to tell them that becoming non-anemic is going to improve their day-to-day quality of life and also impact the
the future generation. So a woman with anemia is going to be not a very nutritionally able mother, either for the progeny in the womb nor after birth. So that's one thing. If she knows that her health status is going to impact her children, she's bound to pay more attention to anemia than, you know, if you tell her you eat well, you cook this, you feed your family this. So I think one way to make the women aware is to tell them the impact that anemia has on their day-to-day life and on the lives of their children. So that's one aspect. Another aspect is that telling them that what they have could be passed on to their children through their genes. And it's not just the woman, the man is also a carrier for blood disorders. So if there is a father who is a thalassemia carrier and a mother who is a thalassemia carrier, they're going to have a child who will be dependent lifelong on blood transfusion. So if we tell them how significant it is, I'm sure that they will come forward to get diagnosed, detect carriers, and therefore be available to whatever counseling and interventions we offer them as medical professionals. That's one thing. The other thing is that women as such, all of us have emphasized on that, have somehow their access to the facilities that we all are willing to provide is not what it should be. So how do we make it possible for the woman in the home to reach out to accessing these facilities? I think if these two, we can look at these two approaches. One is creating awareness, and second, make it more easy for them to access these facilities. We can prevent the compromise in health that women suffer from, and also their children. It of course has impact on the economic well-being of the society, because physically they will become more able if they are less anemic.
Thank you,
and
Dr. Gayatri.
that's the point I'd like to make.
Thank you. May I now request Dr. Anand to share your views, please.
Yeah, I am Dr. Anand. I am a dermatologist and American board certified hair transplant surgeon. I did fellowship of ISHRS fellowship in hair transplantation also. Yeah, today I would like to make the 3 points regarding to our specialty. Already in 2018, central government has banned the cosmetic creams, especially the fairness creams which contains topical steroids, and also the combination of fixed combination of topical steroid with antifungals and topical antibiotics in 2008, because most of the people, especially women, they used to use the cosmetic creams like fairness creams that they're addicted to it, and it damages their face. In a similar fashion, and now then unqualified people are performing the cosmetic procedures. Right now it is in the market, a lot of centers, and unqualified people are doing the procedures like hair transplant, lasers, Botox, all this. So I would like to request they should make stringent regulations must be made to put in place to stop these amateurs, because innocent people, especially women in particular, will choose those type of people for the treatment that causes the complications and issues. And second point I would like to make, that educating the people, especially women, regarding the genetical disease, especially genodermatosis, because these are the burden to the women, because once their child is with genetical disease or genodermatosis, so educating or making some policy to make it compulsory to make genodermatology diagnosis during the first trimester of pregnancy will make a lot of relief to the woman. And third one is policy to make compulsory mandatory testing for HIV before marriage, because this will protect the innocent women from getting infected with HIV.
So may I request now Dr. Deepthi.
Hello, ma'am. Ma'am, I'm a general surgeon, and the most common thing that when patients come to me, the most common thing they tell me is, ma'am, we searched a lot for a female general surgeon, and finally we were able to find you. So we have women who are suffering from problems like piles, fissures, fistulas for months or sometimes years, and then they ultimately find a female and then they come and take treatment. So if we can make information about availability of female surgeons accessible even in rural and tier 2, tier 3 cities through either primary health centers or through print and electronic media. And we can have regular health programs, education programs, where we can explain these things to them, prevention as well as treatment. It will be a great benefit to them. The second thing is for emergency surgeries, usually the woman gets treated, but for elective problems like piles and such things are elective problems. The woman is not the earner of the family a lot of times, so she is dependent on the man's decision whether or not she should go for the surgery or not. So unless the man pays for her treatment, she is stuck. So if we can find some sort of an extension, I was thinking of the Sukanya Samriddhi scheme, which is there for girls. If it can be extended in some way to include women, where it can be some sort of a insurance where the woman can claim it. One is to go for regular screening tests, as other doctors were mentioning, for different cancers and osteoporosis and all, and also for their treatment as and when needed. So then it will be easier for them to take that decision that yes, they are suffering and they want to go for surgery and they will do it. So that is something also which I was thinking about. Thank you.
Thank you. Thank you so much. May I now request Dr. Sudhir Kumar, please?
Thank you, ma'am.
Neurologist.
I am a neurologist, and so today I will be focusing on women problems related to neurology. In that there are 5 main things. One is stroke, second is epilepsy, third migraine, and then multiple sclerosis and pregnancy related complications. So stroke, as we know that it is one of the 3 most common causes of death and disability. Cancer and heart attack have been discussed, and we used to think that women suffer less from stroke, but in the last few years we have seen that they also suffer because the lifestyle risk factors like obesity, PCO, insulin resistance, diabetes, unfortunately smoking, alcohol consumption, all have become more common in women also. And so one thing is that the screening for these risk factors should be done, and maybe because many people have pointed out, because the expenditure on women's health is generally less from the family point of view also. So whether they can be done at a subsidized rates for women. And other thing is women, because whether we accept or not, women have to handle home as well as office. So the time for physical activity which women deserve is not there. So whether the office hours for women can be cut by 1 hour, so that time can be devoted to physical activity and exercise, which is very important. We have to accept that. The second disease is epilepsy, where we have been hearing that epilepsy is a common problem, but unfortunately still there is stigma and discrimination in the name of epilepsy. Women with epilepsy, they have to spend 5 extra years to find a suitable match, and the story doesn't end after finding the match. They get harassed by the in-laws, the husband, saying that you have a mental disease. With respect to mental health professionals, we also deal with that, and several counseling sessions are required to convince the family that it is a disease and which will be normal. So we need to have stricter laws, where if any family is found to be discriminating or stigmatizing women with epilepsy, they should be punished with harsher laws. And then the third disease is migraine. Migraine is a silent cause of disability. Unfortunately, again, it is more common in women. For every 7 to 8 women, only 2 or 3 men have it. And migraine, because women are well for the other 20, 29, 26 days in a month. So they, if they are suffering from severe headache, difficult to get them leave from the office. So we have to impress upon the employers as well as the teachers that 1 or 2 days in a month, she may have severe headaches, so just be kind and give them half day or 1 day leave. And so that is something we have to educate society. And multiple sclerosis, it's a cause of disability. Again, unfortunately, more common in women. They can lose eyesight. It's a cause of disability. The main thing is now we have treatments, but because of cost reasons, many women can't, afford the treatment. And unfortunately, just like mental health, this also is not covered by medical insurance, even though it's a disease of brain spinal cord. So we have to impress upon insurers that, please include MS treatment also. And the last one is pregnancy-related complications like cerebral venous thrombosis, eclampsia. And so we need neurologists and neurological treatment available in district hospitals also, so that they can accept. So just to summarize, So women definitely deserve to spend more time, doing physical activities, so 1 hour less work in the office. And then second is we have to provide for maybe equipments in the office also, because they can, if they're free, they can do a little treadmill, little cross training or something, 15-20 minutes in between the work. Even men can also use it, why not? So that is because, and then other thing is, we are providing rations like say rice, wheat in the fair price shops. Why not include fruits, vegetables, nuts, and even healthy food, and increase the taxes more on the ultra processed packaged foods, sweets and soft drinks, which are all again bigger risk factors for women also. And then the treatment gap, which is more for women, if we can have, we have Ayushman Bharat scheme. So probably, we can cover, we give greater coverage to women, for the same premium. So they'll be encouraged to seek treatment and not sit at home till the last moment. When we get patients, women patients, most hospitals, even CMC where I worked, only 20% beds were for women, 80% for men. And our colleague also said most patients are, women in this thing. So many times, it's not that women don't fall sick. They are not brought to the hospital for treatment. So, they need help in that area, and then avoid discrimination in the name of gender, especially with epilepsy. Thank you.
Thank you very much. Madam, we have two doctors in the integrative medicine. So now may I request Dr. Venugopal Gauri to speak, please.
Your Excellency, Namaste ma'am. India is no more a developing country. Probably we have many pockets of developed country, especially in the southern part of our subcontinent. And unfortunately, despite being so, having better access to nutrition also, apart from the underdeveloped population or the lower income population, the upper population also do not have proper nutrition, in the sense due to improper diets. But at the same time, assimilation is one of the main issues that causes the problem with cases like anemia. And as a homeopath, ma'am, I can tell you that we have good propositions of medications or where we can improve the supplementation. The second thing is, ma'am, about the hypothyroidism. Thankfully so, for the past few years, screening for thyroid has become a sure thing as far as antenatal care is concerned. But having said that, because of stress and strain, as celebrated psychologists and psychiatrists were saying so, the autoimmune part of the disease does not allow the thyroid to function back to its normal self despite being supplemented for a long time. This is also a place where, as homeopathy remedies are concerned, we can play a big role. And the third thing is, ma'am, the World Health Organization says lactation is one of the most important things. They are going to focus more about that in this particular year. And we have some great remedies that can help in such an area, ma'am. And the last thing about similar disease is about osteopenia and osteoarthritis, which can lead to many diseases in a woman mostly. So apart from the regular conventional supplementations of iron, vitamin D and other things that, of all the four things that I was saying, ma'am, we have good remedies that can improve density of the bones. So if these are made available at all the primary health centers of the country, ma'am, it doesn't need a homeopathic physician to actually prescribe it. Any conventional medical person also can actually supplement it along with whatever supplements they are giving. So it will go in a long way in improving the productive population of the country, especially the women, ma'am. And having said so, ma'am, Your Excellency, you are one of the proactive governors that our country has today. As a proud homeopath and Ayush professional, I would say that we want to be a part of the growth story of the country, and we want to spread our tentacles the world over. We want to bring back a lot of revenue for our country. In quick time, as Ms. Chandravva was saying, from the 5th spot we would jump to the 3rd spot, as our Prime Minister has envisaged in the Parliament recently. This can happen if Ayush, the knowledge capital of our country, is made use of. All we need, ma'am, it's not money. We don't ask for jobs. We don't ask for any investments. All I would say is we want a memorandum of understanding between our country and those countries. and we would do our bit to bring back a lot of revenue to our country, ma'am. That is the way we are going to be a Vishwa Guru very soon. Thank you so much, ma'am.
Thank you, Dr. Gauri. May I now request Dr. Wajida to speak.
Thank you, and thank you for this opportunity to this summit. And I want to really share something which is complex. Me being very conventional doctor, I have been practicing gynecologist almost 30 years. I am in the practice, and always I have seen that most of the times we look at the pathogenesis aspect of the diseases. And it's all about, that is, we all do usually. But there is another world called salitogenesis. The salitogenesis is looking at the holistic approach involving the component of, all of you know, physical, mental, social and spiritual well-being. And it is about responsible, we are looking at the factors which are responsible for well-being rather than the disease pathogenesis only. So this aspect is called traditional complementary integrative system. It's not only alternative. So we do what we do as a conventional doctor, but we also bring our traditional integrated natural system. So this is actually there in Europe. They have been practicing since 100 years. So when I saw that, and I was really inspired, and I thought, why not to bring this to our own country? And that is where patient-centric, and it is win-win situation. And I'm very happy to share that our respected Prime Minister ji has also encouraged this. And in Jamnagar, WHO Integrated Medical Center office is opened, and we are going to have 17th and 18th of August. We are going to have a global summit, first WHO Traditional Medicine Summit. And having said that, this is something which is, I feel, could be the future of healthcare in the world, in our country, especially our country where we are already rich in traditional medicine. So how we can say that? Like we, most of the times we say health, we also say health is not freedom from illness, but state of physical, mental, social well-being, right? Then the diagnosis also depends in all the 4 levels. We have to find out where there is something missing, not even in the physical domain, in emotional, social and spiritual domain also. So that way we can deal with diseases, many diseases. Like for example, most of the diseases we are actually lost, like cancer.
Is there a discipline that you would like to speak about?
Pardon?
Is there something like specific,
cancer, yeah.
I mean, do you follow a method, like,
yes.
What is your system that you follow? Because this alignment, I think we know we're running short of time. Just haven't finished it, that's why.
Yeah, for example, I will give you about the cancer or multicentric approach.
So if you can mention.
Yeah, so what we do is any illness with the physical, with the diagnosis and everything, cancer, we also treat, it start with the counseling is a part of it, emotional health is a part of it, nutrition is a part of it, and family counseling. So everything, it becomes multicentric approach. And we also use herbal products, like there is an injection, mistletoe, which I use extensively, which also has, which is integrative and which complements our chemotherapy, radiotherapy, reduces the side effects, enhances the apoptosis, it decreases angiogenesis. And all of this, what I'm talking, is well evidenced and well researched. So this medicine, I feel this could be the future, that where conventional medicine and natural medicine can come together with this bridge. Thank you.
So we'll look forward to getting a note from you. Madam, just 2 more quickly. One, nutrition, we have Lahari. Quickly your points, please.
Yes. Hello ma'am. Thank you for all the doctors making all very important points regarding nutrition. So I'm not going to reiterate those. I just have 2 points here. One is we're all talking about good nutrition, but there is limited access to healthy foods. due to constraints in accessibility as well as affordability. We all know what healthy food is, but when we go to a market and we compare the prices of or ease of access to unhealthy food versus healthy food, we all know that we can lay our hands faster on the fast food and unhealthy food. Ironically, that is much cheaper than if we really want to eat healthy food, especially pesticide residue free and probably hopefully organic as well. This is not just limited to fruits and vegetables. This also includes, this year is International Year of Millets. So I want to include millets also in this. So if we want to buy a kg of millets versus a kg of fully polished white rice, the price of millets is double the price of fully polished white rice, if you all know. So the accessibility is really, really important. So I wish something can be done in this area, making healthy food more accessible. Second point, when it comes to fruits and vegetables, it's excellent. You know, Dr. Sudhir has mentioned that if we can get fruits and vegetables at a subsidized rate, adding to that is availability of local and regional fruits and vegetables that we are not seeing these days in the markets, especially leafy vegetables that are local to the area that we used to see even 10-15 years ago. We don't find those. There are about 3 to 4 different kinds of leafy vegetables that we can see in market these days. So I would like to see some action in that area, encouraging more people to take up cultivation of more regionally grown foods that their nutritional value is obviously much better than foods that grown elsewhere and traveled a lot and put in cold storage and everything, because every day a food spends on a shelf after harvesting, the nutritional value keeps going down. So the fresher it is, the better it is, and if it is local, the freshness can be ensured. Coming to the second point is about safety and hygiene. Now that women are playing multiple roles, you know, as Dr. Sudhir sir has mentioned, women are working, yet they still have to take care of the household's food needs, if not everything else, let's say. And for that, a lot of women, including myself, sometimes have to depend on purchasing ready-to-eat foods, whether it is ordering online or just going to a curry point and picking up whatever is available. Here we are also putting our health at risk because of the hygiene and the kind of ingredients that are being used in preparation of these. When it comes to quality of ingredients, there are standards set in place, but how good is, you know, how well is the implementation of these standards? Like, how is the monitoring process? As well as how good is the potable water that is being used in preparation of this food? Because I myself have contracted hepatitis A at one point because of eating this food. So I wish something can be done in the area of accessibility to potable water to ready to eat. And just one last point is, as a nutritionist or as a qualified nutritionist, I also see a lot of social media influencers dishing out nutrition advice, which sometimes ended up causing more trouble, and most of those people would end up with all the doctors here because of the wrong advice they took. So I think we need a policy about who can actually give advice about food. I know everybody eats it, but just because we eat it doesn't make it, you know, doesn't make everybody an expert in that area.
Yeah,
So
that's a great
all.
point.
Thank you.
So ma'am, there is just one last, I think one ophthalmologist gentleman, and then we'll come to you and we'll close, and madam will give her speech. May I request Dr. Hari, please? Samita, would you like to speak on behalf of
Ma'am, thank you for this opportunity, ma'am. I would be presenting on behalf of Dr. Hari Kishan, my father. So first I would like to start with a note like Sarvendriyanam Nayanam Pradhanam. So coming to the risk factors in women face the higher risk of blindness than men. And women take up to 65% of the AMD cases, age-related macular degeneration cases, and 61% of the glaucoma and cataract cases. And 66% of the blind patients are women. So here I would like to bring up with 6 different points. First of all, like visual disorders predominantly found in the women are visual impairments, like uncorrected emetropias, like myopia, hyperopia, presbyopia, astigmatism, and dry eye diseases. This is more common these days. So all these all these disorders influence are influenced by the changes in the hormonal levels in the women, especially estrogen, progesterone, and even testosterone in different phases of the life, like menstruation, pregnancy, and menopause. So policies should be made to develop an educational and screening programs to educate women for the loss of productivity, impact on the quality of life, and potential morbidities like psychological problems like anxiety and depression, which should be addressed here. In modern world, like cosmetics have been very casually used, like eyelid makeup, like eyelid cosmetics, like artificial lashes, the glues which are used. Harmful chemicals and ingredients are used in this process. These are causing lot of ocular surface disorders, which there should be strict policies to prohibit such ingredients in these beauty products. Next, coming to amblyopia, retinopathy of prematurity, diabetic retinopathy, and glaucoma. These are the potential blindness causes after cataract, which can be prevented when screened and treated in time. So there should be compulsory and almost should be made compulsory screening policies where all these are screened. Amblyopia at school going age, like 6 years, at a very young age where the child get admitted, and ROP right at the birth in the hospitals, and within 1 year of the age. And glaucoma and cataracts should be screened from 35 to 40 years of age of every individual. And diabetic retinopathy as soon as they are diagnosed, and further they should be followed up frequently. Abuse of antibiotic eye drops have been very rampant these days. So this should be monitored, and strict policies should be made to prevent this abuse of antibiotics, because we have already developed resistance to many antibiotics right now. Then nowadays, like 50%, 80%, 80 to 90% of the postgraduates are women in ophthalmology. So due to lack of proper training facilities and lack of teaching staff, the standards of training have come down. So by the time they complete their post-graduation, they need to spend 3 more years for super specialties. And by the time they come out of these training facilities, they are 30 plus and 35 plus. So I would request there should be some policies, because this is causing, by this age they have to manage the family, profession, and they're causing many psychological and financial burden on the women.
Yeah.
So there should be some policies where micro and microscopic surgical fields are involved. The post-graduation and training should be done much younger age. Should be completed by much younger age.
Thank you, Samta.
And one more last thing, ma'am. So this is regarding the medical equipment, the burden which an ophthalmologist faces. In establishing an ophthalmologist hospital, so 92% of the expenses go for medical equipment. So most of the equipment, 94% of the medical equipment are imported. So imported. There's no stringent laws or policies curbing the cost and service contracts which these multinational companies make. So we should encourage more indigenous medical equipments where we can reduce the cost burden so that it can be transferred to the patient. Thank you, ma'am.
Thank you, Dr. Samta. I think now we have our last speaker,
Thank
Dr. Shanta Kumari.
Thank you, madam. I want to enlighten one thing. I would like to comment my daughter's talk. Previously, it was this on ophthalmic medical equipment. Customs duty was 0 because the sight-saving equipment on that class, the central government exempted totally, and after that, 10 years back again they introduced, and they introduced 2% on this ophthalmic equipment. So sight-saving means it is a life-saving. In this entertainment world, if they lose sight, almost like dead, and it is a very great burden to the community and great burden to the nation also. So
Thank
please
you. Thank you,
Respected Governor Madam, Your Excellency, please forward this my humble request to Tamil government. Thank you, Madam.
Yeah. Thank you so much. I think this request has come to our Finance Minister Nirmala Sitharaman from practically every domain. So now we have the last speaker. After that, Madam will give her speech.
Thank you very much. We are gynecologists. We feel at FIGO we are the global voice of women. But today I've seen each one of you have mentioned literally every aspect of women's health. There's nothing left. But most important, I think what we need to understand is right to universal health. That is the most important, because I was at the UN meeting also. It is the right to universal health without gender disparity. So the most important SDG goal 5, gender equity, is the most important aspect, not equality, equity. Equity. People who don't have enough have to be. So it's now time. All have seen that women are at a risk of diseases and burden, and they have their right for equity. I think that is most important, madam, which we need to look at it. And all the diseases, right from preconception to the cancers, to the vaccines, everything has been covered. We have been doing everything. In spite of it, anemia is 60%. So we all know that there are hundreds of programs which are happening in the central government and the state governments in the country. In spite of it, we are seeing all these problems. So we need R&D for women's health. That is very important. And the most important data, women-centric data, that's not only in our country, globally, there is a deficiency in women-centered data for disease or outcome. That also we need to focus. And most important for this is no to violence against women. That is important. We have initiated DERA, no to violence, any sort of violence, psychological, physical, mental, and any sort of violence has to be addressed, and you need to catch them young. Education, everyone has actually spoken of it. From the school, we have been doing the online school certification program. Tell the boys and girls you all are equal, and they need to grow up to a gender neutral society. Be it health or nutrition or education, everything. I think that is most important. Everyone is doing the school program. The curriculum is getting changes and vaccinations, everything. But I think reinforcement and equity are very important. Thank you.
Thank you very much. Madam, we've come to the end of their contribution. We request you to give your address.
Special good afternoon to each and everyone. Really, it's a very productive meeting, and I thank Skarna Gopal for organizing this program. And even though I had a very hectic schedule, actually today I got up at 4 o'clock and I landed here by 6 o'clock, and immediately went to a South Media Summit. And then yesterday also I travelled from Puducherry almost 3 hours to reach Chennai, and then I came here. Particularly, I am very happy that such programs are organized in Raj Bhavan. So Raj Bhavan, so it's more productive and more protective also. So I want to not only physically but medically and mentally also, particularly to serve the people of Telangana. And I am really very happy that, as Madam Santakumari said, almost we thought, oh, gynecologists, we are only confined and we are only the sole proprietors of the womenhood. And you have more and more role to play and more responsibility. And I'm really very happy it is focused in a very precise manner about womenhood. And all the awareness, everyone was telling about awareness, and most of the people are focusing on the uterus and ovaries, and most of them, they forget women also have brain, women also have heart, women also have kidneys, and women also have gastrointestinal tract, and women also have should have peace of mind. So nothing is focused. So childbirth and gynecological problem, and the child, when she is bearing the child, the whole family will be appreciating her and lauding her, protecting her. One child is born, okay, next she has to go for her work, whether it is physical work or homework or her official work, something. So I'm really happy that policy decision committee has focused particularly on women, and it is need of that, and we have been talking for 75 years about women. But yet we have not come to a conclusion, and yet as it is said, 80 beds are for men and 20 beds for women. And I very clearly said, I read one statistics. Actually, one of the conferences, because I was working as a pediatrician also, as gynecologist also, and sonologist also, and a social person also. So I used to attend gynecology conference also, pediatric conference also, and sonology conference also. In one of the pediatric conferences, they projected girl children are more resistant, and have more immune power. And the statistics projected was the under 5 OP, outpatient department. They projected more male children were brought to the OP. So female children are very healthy under 5, and they are more immune, and like that. Then we told this, we asked about the statistics and everything. They concluded like that. But one of the social person, this happened when I was postgraduate in gynecology. One of the social person stood up and vehemently opposed that statistics, and she told, girl children are not brought to the OP. In spite of the suffering, male children, if they have minor ailment, immediately they are brought to the OP. The girl children are not brought to the OP. So when they are not brought to the OP, obviously you have statistics. So that is the main thing. So from the childhood, and I always narrate on, as a sonologist 30 years back and all, we can disclose the sex of the baby. And the patients will come and ask, not sonologist mission, Ana Panna Pakra mission, so that whether it's male or female identifying mission only, they will tell like that. And when a girl child is born, immediately girl child is identified, the mother will cry, and mother-in-law will scold her, and you told there are no strict laws, but strict mother-in-laws are there, strict daughter-in-laws are there. So it is very difficult to face them. Then after this, and after delivery also, I had a very pathetic case during my house urgency. We had twin babies born, 2.5 kg, and one was, twins means regular monitoring is needed. Then one was gaining, female was losing the weight, male was gaining the weight. And then we did all the investigations were normal. But at the same time, we were inquiring, they told, are feeding more, feeding when they are crying, we are feeding like that. Suddenly I thought that you are she was a very emaciated, very undernourished village mother. So we asked whether you have adequate breast milk. Then she told, my mother-in-law asked to give my whole breast milk to the male, and the female we are giving diluted cow's milk. So this is the, this was the pathetic situation. I cannot say the situation has totally not there even in the villages now. So another thing. So the womenhood, whether it's tip of the iceberg only, the development, I always think that, we have so much of posts there, and governors are females, and then even president is female, but downtrodden, the development is tip of the iceberg. So only we, and nutrition part, first of all, whether we concentrate on disease or not, because good nutrition can prevent what all the symptoms and what all the diseases. So basic foundation is nutrition. Personally in Telangana, when we went to the tribal areas, we have adopted 6 tribal villages. And when we, with the help of the ESIC hospital and National Institute of Nutrition, we did medical camps, and we found the tribal women had only 4 grams of hemoglobin. And then we told them to take medicines, but they refused. As it is said, some of the traditional method. Then we found that mehua flowers, which they take for addiction, and we did with the help of Institute of Nutrition and ESIC and even Red Cross, made laddus with mehua flowers, and now we have given that, Raj Bhavan is pending, and we have given that, and now the nutrition status of the women are improved. So it is 6 villages we have shown the improvement, and we want it to be implemented in other areas also. So, but after that, actually we know the premature deaths, young mothers, they die, maternal mortality is more among. So after adopting this method, we physically, visually see improvement in their livelihood. So this is one. So and another thing, most of the governments give the nutrition kits to the mother in the 3rd month, 6th month, or during last trimester. You all know preconceptional stage is the most important, and that is not, patients are not concentrated on that period. Only after pregnancy, after diagnosis, and with nutrition is needed, but it is not needed as such in the preconception. So the government policy should be in the preconceptional stage. So another thing, adolescent stage, adolescent girls are mostly ignored. And I always say in the schools also, don't treat the male children of that age female children, because male children doesn't have much of the physical problems, the bodily problems, but girl children, they have 3 days menstruation and premenstrual tension, they have premenstrual depression, they have. So don't treat the girl children the same as the male children. So adolescent age. So from the birth we have to concentrate on the women, but particularly adolescent. And we traditionally we are losing certain things. Corona based integrated medicine, I am really very happy, because I am a person, even though I am an allopathic doctor, I strongly believe in the integrated medical system and preventive system also. I really laud our Honorable Prime Minister about the Yoga Day, because yoga gives answer to so many things, particularly obesity. Most of the things, the basic problem is due to nutritional factors and the obesity. As the bariatric surgeon told, it is overnutrition. And awareness, because one of the friend told about the vegetables, local vegetables, but we had a practice of sowing seeds in the house and taking it every day once. A problem in our family is, when it is cheaper, they don't think. If a boy comes and asks a family, I don't want dowry and I will marry your girl, then they will tell, no, they won't be happy. Oh, this boy is having some problem, so he is coming in forward to marry. The same manner, if some nutrition, because greens are very less in, and you needn't go and buy, even kitchen gardens we can have. So these type of traditional activities also should be, and even in the, I don't know whether that practice is here, when a girl attains menarche, now we think it's a fashion to hide it. But in the villages, they are very proud that child has attained menarche, and they used to give this green gram, black gram laddus, and they used to give raw eggs, and they used to give the sesame oil. So these all strengthening the calcium content, anemic content, and strengthening their bones. So immediately when it is needed, our ancestors, really I used to laud them, because as we know the nutritional aspect of those things. So exactly during the menarche, they were giving it, and mental also, because they had some program. They used to tell, no, why to propagate? It is not to propagate. Other children will come. So this is one of the phase we have to pass in our life. We have to face in our life. So they had a knowledge about it. But now, even though they have wrong knowledge, they go to internet and they browse for different things, that correct message is not gone to them. So this type of education is more needed. So first of all, first and foremost, nutrition we have to. And another thing, as somebody told, pharmaceutical, I have seen. When I was house surgeon at Chandravva Medical College, it's a peripheral hospital. We used to give iron tablets. When we go for lunch at the backyard, we used to see the iron tablets thrown in the ground, saying that it's black in color. So if we take it, our baby also will be black in color. But in a lighter sense, I also know we are all black color only, we have become doctors. And in a lighter sense, I used to appeal the pharmaceuticals. Please produce iron tablets, multicolor iron tablets. Because like saris, women like multicolors. So even these are subtle things. We think that we have given iron. So we have to introspect, even though the plan is there. Even, for example, somebody told about the sanitary napkins. In Janaushadhs, for 1 rupee we are getting the sanitary napkins. Even we are not aware of our disease and we are not aware of our government schemes also. And even nutrition, that in Janaushadh shops, the nutritional protein powder, the anemic tablets and all much cheaper. For example, if it is 1 rupee outside, it is only 10 paise. And even government hospitals are providing. Yeah. So these things should be, we have to learn about that. Then insurance scheme also. Ayushman gives for more treatment before and all. Cesareans were not included, women diseases were not included, now it is included. So and National Health Mission. Somebody told about Universal Health Mission. We have National Health Mission. So National Health Mission, every woman should be screened, every woman should be screened for cancer, every woman should be, but it is not implemented the way it should be implemented. Lack of awareness, because we conducted in the health initiative allocations in the union budget also. We did, but most of the people are not aware. Because National Health Mission, we have everything, particularly women, they have to focus. And nephrologist told about dialysis. And in Puducherry, we are going to adopt the Gujarat model of dialysis, where they have 100% they are reaching. Other areas, for example, dialysis is needed for 5 hours. Poor patients will have dialysis for 2 hours and they will pay for 5 hours and they will pay. So, but our Prime Minister's dialysis scheme is there. But patients are very hesitant to go to the government hospitals because it is our mistake that we have not given hope that government hospitals also can give good treatment. So they are spending their money and then dialysis 2 or 3 months they will go. It is needed eternally till the transplantation. They don't know that. And they die of renal disease. So these all things. So first of all, according to me, we can, women, as it is said, ophthalmologist 90%, but gastroenterologist, they need a colonoscopy and other things means, according to our tradition, it is very, even gynecologists, because even pelvic examination, they will be, in the village people, they will be so hesitant to do, and then we convince them. And I very appreciate about the pyramida we have created. Some thought, we have everything. I think we have to reorganize certain things, that's all. For example, 1 hour. Women, in Puducherry we are giving 1 hour concession for working women. It is just recently introduced and it is, it is given in a good intention. But the opposition parties told, some of the opposition parties told, you are again making women empowerment is tarnished. You ask them to work in the house for more than 1 hour. And we are not like that. We wanted her to relax. We wanted her to work out because she can work out when her husband has gone and children has gone to the, otherwise she will be confined to the family work. So that is also given. So small changes. For example, another thing which you are all talking about relaxation. Yesterday we have introduced a no bag day. Children were so happy and they came with it because that relaxation. Last month day is known as a bagless day because whole month they are carrying. So yesterday they were, I was also playing with them and so they were, immediately when I entered, thank you madam for not bringing the bag, something they were telling. So that relaxation, whatever, whether it is children, whether it is ladies, even men, because when ladies are relaxed, men will be definitely can be relaxed. When they are tense, they are tense. I always say it's not just in lighter sense. Females maybe could be administrators because they can manage men. But men cannot manage all women. It is very, very difficult. So when women are happy, the whole society is happy and the whole family is happy. So we have policies, and I really, as Ms. Karna Gopal told, Honorable Prime Minister focuses on health more. So only he brought Ayushman Bharat, and he had stents and all, 40% reduction in this stent before and all. Stent means it is only for very rich people, even the auto drivers, our brothers working in a very simple manner also, they are also getting it in knee replacement, women for women, and this exposure to sun, this and all we have to, we have lifestyle changes, and so only our Honorable Prime Minister is now in slightest change in anything, so that it will have a very good effect on your, So I'm really very happy, but my request is, in each speciality, what can be done for women? Now you are getting their reports, and awareness should be created not only by doctors, by social persons, and it should start from the school level, and it should start from the college level. And I had an anemia-free society program among the college students. So as a gynecologist, I used to go for interaction. If the child is having over menstruation, the child won't ask she is suffering from. She will ask, my friend is having 7 days period, my friend is having 10 days, she won't. So there was an outlet, there was a guidance for her. Most of the children, I have to, very painfully I have to narrate one incident. One child from Madurai, when I was house surgeon, when I was postgraduate in gynecology, she was putting on weight. Mother was scolding, you have to get married, why are you putting on weight? And she was going to gym, and she was going to the beautician, and I have to say the cosmetologist, there are very, very thin balance between the cosmetologist and the dermatologist and the beauticians. So most of them go there and get creams, and there won't be a permanent solution. This child was, the whole family was scolding her, and she was exercising, not taking any food, and she was suffering from ovarian cancer. When she was brought to for scan, I was only doing scan, and it was in a very grade 4 stage. It would have been, because immediately obesity means then another thing, we have whatever the girl child says, immediately it is not getting the attention. And even if she is sexually harassed, and if she has some problem, you should be proper. Why are you going there? So we have to be very careful in handling. I always say, you have to handle the girl children like a glass. Should not too tight, it may break, or if too loose also it will go fall down and break. So these are things. So as a doctor, also as a social person, first nutrition, adolescent nutrition, girl-child nutrition, preconception and nutrition. Menopause is a very, 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 very important topic. Nobody is concentrating. Why mother-in-laws are irritated? Because mother-in-laws are in the menopause stage. So only our custom say, no, you get the blessing of her, you fall on her foot and then get it. So it is mentally making them, okay, we are also taken care. So these type of our traditional things which were taking care of the mothers and grandmothers also should be taught. So we have to back to roots, because Corona taught us as its integrated method. And I am very happy that I'm a strong believer of Indian medicine. So even though if I thank God, because I'm traveling this and all, because I integratedly I take that immune pepper and this and all, I take more. And first of all, whatever may be this thing, and another thing, whatever may be the scheme, should be enforced in a proper way and ensured that it is taken by the children. For example, we are introducing millet laddus. In Puducherry next week, millet laddus are given to the children. So such things, when it is given in the schools, burfis can be given. Coconut burfis are more nutritious. So children nutrition can be taken in that way. And preconception stage itself, mothers during marriage itself, and this vaccine, Indian vaccine to prevent cervical cancer, that should be propagated. And one thing is that women health should be the primary factor for everyone. And school also, continuous education should be there. 1 hour in a month or 1 hour in every 15 days. Health education for girl children should be there. Particularly in the adolescent age, they are unaware of the bodily changes, and mothers are not very competent to explain it. When it is taken in the school level, it will be very good for the children. Second, awareness about the hygiene. And Swachh Bharat, as you said, most of the dropout girl children, they've experienced dropout because there were no toilets. So toilets are very important, and even developed states also lack in good toilets. So we have to concentrate on that. So then coming to the neurology, nephrology, cardiology problem, first her mental well-being, her physical well-being, and somebody told about gym in her. So they should make serial. When you see the serial, you walk. Don't cry only. you try walking and then do some yoga. So because everywhere we cannot give equipment, so that awareness also, don't going on sitting and see constantly, because now IT people we are telling, no, you sit and then between you close your eyes for some time, and then and another thing to be concentrated is IT female professionals. All problems poor girls are facing: delayed marriage, PCOS, obesity, and lack of nutrition. And there was a study in Telangana, fertility problem also. There was a study in Telangana, one of the NGO organization went and opened the tiffin box of each and every child. That happened in Telangana. And 90% of the tiffin boxes had burgers, breads, chips. No traditional food at all. So this awareness should be created among the women. Please do some idlis. Idli in dosa, at least each and every time you have to put dosa. And some idlis or some pongal with all legumes, everything can be done. So cooking awareness with nutritional aspect, because obesity is more, because children, they are given 10 rupees, okay, get something. So they are getting something and they are eating that what they are. I always say, we are calculating our currencies, but we are not calculating our calories. So that is very important. So from the beginning, calorie maintenance and physical activity, nutrition, that will curtail most of the disease. First phase. Second phase, what all the problems, for example, neurological problem, gynecological, endocrinological, what all the problems sorted out. And it should be concentrated in the medical checkup. Mostly her medical checkup confined to, gynecological, this thing. Everything should be included in that. And female ICUs, female wards, a little more in number, and mobile clinics for females. Mobile, because they won't come, they can't come. And mobile health checkups for women, particularly rural women. And we have to concentrate, because officially we can say every ration card, every Aadhaar card, we can have a data, and we have to concentrate. If a village is there, it is not the 10 village person, 100 village person. Every person should. In National Health Mission, we are doing that. I don't know whether states are doing that. Because I am directly in the administration, I am telling about Puducherry. And all these things, if it is done, definitely women will be very happy. And instead of some sanitary package, because Red Cross gives a package like that, sanitary pads, some disinfectants, some solution, some towels, like that. So if we want to gift a child, girl child, we can gift them with such activity, such thing, this thing. So from the school level, we have to, this is more hygiene and nutrition. First we have to come, in a phased manner we can go. And I appreciate all the specialists who concentrated on, as it is said, more incidences are there. And even they think heart attack also they won't affect, because after menopause we know the incidence in women are more than men. But another thing, families are not allotting money for their family health checkup. The budget, first thing cut in the budget is women health. And women also, we have to, I always narrate one incident when we were house surgeons, postgraduates. There will be one exhibition that I have already narrated in some of the conferences. The sari shop will be there, jewelry shop will be there, cosmetic shop will be there. So we pleaded our head HOD so that we all postgraduates collected money. I always, in social perception, it's not only after I became the governor, from my postgraduate days itself, I had a very social outlook, so something should be done. So we collected money and we hired a stall and we had charts and all for how breast cancer will be diagnosed, and then we had a pap smear and we had a mobile mammogram, everything we had. And we had we wore our coat and with stethoscope, we were all sitting, these ladies used to come. First they enter the sari shop, then we will be very eager to, they will be entering, very fast they will cross us, then they will go to the jewelry shop. So they are not also interested in, so they think that nothing will, so women also should have, then they will tell, even for a husband, if they are stomach pain, gastroenterologist should see, should consult, and if a child is having headache, they will consult a neurologist. But if they can, then kitchen they will go, they will take some asafoetida, some pepper, and they think they are sacrificing. That sacrifice, it is not good for the family also. So first of all, awareness, and then happiness, and yoga practice, and institutions, and mothers should be taken care. I always, whenever I talk about yoga, I used to talk about women sari yoga. So traditionally, they immediately, they told, no, I don't have the yoga dress, so I won't. So naturally, with the life pattern, for women something should be taught. Otherwise, if you want them to take away from the family pattern and traditional pattern, they won't. So go with them, along with them, collide with that, and then we have to. So these all things, because you all have done, did very good, but in added points only I am telling, because they have covered very well. Even though we gave 2 minutes, I really appreciate you. They have done very well. Yes. And TB Mukt Bharat by 2025, our Honorable Prime Minister wants India to be TB Mukt, and the Nikshay portal. Actually, Raj Bhavan has adopted 100 patients. That government schemes, if we align with them, it is very easy, but we are not doing that. So that was what all the sickle cell anemia free by so these all things we can. Endometriosis, I have to say, endometriosis is very common, and it is not identified properly. And I have my own experience as a sonologist. When we diagnose endometriosis because of some disparity in the myometrium, mostly before and all they won't accept. But after that, I myself have presented a paper of with just the thick myometrium, maybe endometriosis. And the pain they experience is something, so that should be aware of it. So these all things are almost everyone. And another thing, ophthalmology. In Puducherry, we are practicing one model without ophthalmoscope, artificial intelligence incorporated into the cell phone. Just like that, looking, they are now blind free Puducherry, like that we have got one instrument is 60,000 only. Ample amount of instruments can be got, any number can be got, and even non-trained person can, just they have to look into that, and it is focusing the whole of retina. So particularly diabetic retinopathy and all very early diagnosed, one person came and told me, so we have implemented it, and now they are picking up very fastly. I was very, so artificial intelligence in diagnosis also, particularly this ophthalm, the cell phone, Apple cell phone. Yeah. Yeah, very good. So that is also doing very good.
So Madam, I'd like to add all the inputs that have come here. We will share at a startup event, and they will look into it and maybe come out with some medical devices. Like non-invasive diagnosis is very popular. India's first unicorn is a diagnostic company which is valued at 9,000 crores today. It is called SigTuple. They don't invade the body, but they can diagnose cancer. They can diagnose anything practically in seconds. So all the recommendations I'm going to share at a startup event so that they'll come out with medical devices. Now India has come out with a medical device policy. A lot of good things might emerge.
In startups also, medical devices particularly, little more encouragement can be given to them.
So maybe have the vote of thanks.
Yeah.
I request Dr. Vasuprada to propose a vote of thanks.
First and foremost, thank you, Your Excellency, for a wonderful space you have provided for this event to happen. And thank all the professionals, all the doctors who have taken time out to give their bits of very relevant wisdom. And we thank the staff of Madam who have made everything possible here, and the staff of Raj Bhavan who have also helped us have our tea earlier, and I'm sure there's something ahead. And with this, what I would like to again, of course, our members from the press, thank you very much for covering this event, because as you know, this is something that is working towards the health of women, and we all know that in a home we call a woman Gruhalakshmi. For the nation also, a woman is still the Gruhalakshmi. So thank you, Madam, once again for this wonderful event. Thank you.
So this effort should be consistent, and till the good policies are made. Another thing, this day spending so much of, I always say, call sheet of actors, doctors is equal to a call sheet of doctors, actors. So spending all your busy schedule, all specialists, almost a specialist hospital is here, specialty hospital is here. So you are really very happy. I know the value of every minute of a doctor. Thank you. Yeah. Very good. Very good.